Hello, everyone. Sorry if I sound a bit hoarse. My voice, I'm just getting my voice back. Because I was a bit sick over the weekend. But so today I'll be doing a presentation on the comprehensive review on the advancement in the clinical management and treatment of Prader-Willi syndrome. So first things first, we first have to understand what is Prader-Willi syndrome or PWS. It is a rare genetic neurodevelopmental disorder that affects about 350,000 to 400,000 individuals worldwide. If the birth rate frequency is between 1 in 15,000 to 1 in 25,000 individuals. So there are three types of genetic mechanisms that can cause PWS. So they are paternal deletion, maternal UPD, and imprinting defects. And about 65 to 75% of the cases are your paternal deletion cases. This is where there's a failure of genetic expression of chromosome 15, and this is where there's a partial or complete deletion of chromosome 15, as you can see right here. And then in maternal UPD or maternal uniparental disomy, this is about 20 to 30% of the cases. In this case, this is when the mother gives the child two chromosome 15s. This has been linked to age with the mother. So if the mother tends to be a little bit older, as well as some research pointed towards there might be a trisomy within the mother where their mother might have three chromosome 15s and two of them are passed off within into the child. And then there's also an imprinting defect, which is about 2 to 5% of all cases. This is where chromosome 15 is incorrectly placed, or there might be parts of chromosome 15 incorrectly placed with the other side of chromosome 15. This can be heritable, but this very small percentages, so it might be between 0.05 to 0.5% of the cases, which is why it's not really a heritable disease. Most of these genetic mechanisms happen in the formation of the zygote, and as the cell starts to develop into a fetus, things with chromosome 15 might change along the way. So just to get more in depth with the signs and the symptoms, I got more in depth because a lot of the research said that sometimes there can be misdiagnoses because of how similar it is to other syndromes like Angelman syndromes. So just to begin, on the mental and social aspect of the disease, individuals with PWS typically have an IQ between 60 and 70. They might have speech and language delays and deficits, which is why they need speech therapy. They can be from nonverbal to having typical speech and language skills by adulthood, but they do have difficulty with social cues and changes to schedules, which is why they also might misinterpret it as autism. They also have a higher risk to develop mood disorders, anxiety, and obsessive compulsive behaviors. And then when it comes to the more physical and diet aspect of the disease, a big symptom of the disease is, a big symptom of the disorder is hyperphagia, which is like the unwavering feeling of wanting to always eat. Like they don't feel full. They always have an appetite. So that is a big part of the disorder. Then there's hypogonadism, which is a lack of sex hormones. This has led to the underdevelopment of reproductive symptoms. Wow, my English. Reproductive systems. So they might lack certain parts of their bodies. I know for the women, they might not get their menstrual cycles until like they're way into their like 50s, 60s, maybe even a little earlier. So it kind of makes it difficult for them to regulate their hormones and stuff like that. There's also hypothalamic dysregulation, which interrupts their sleep-wake cycle. And when it comes to more physical features, they typically have a short stature, so they might stand at about 5 feet tall. They have a narrow forehead, almond-shaped eyes, a narrow nasal bridge, and a thin upper lip with turned down corners on their mouth. About 80% of these individuals tends to reach obesity due to the hyperphagia and their food-seeking behaviors, which might include eating inedible materials, hoarding, foraging. This causes their life, and because of the obesity, their life expectancy is about 29.5 years, but many individuals can live well into their 50s and 60s. So here, one thing I didn't mention is that in Newborns, one thing or one telltale sign of hy of PWS is hypotonia, which is decreased muscle tone, means that the baby isn't able to really hold their body weight. It's difficult for them to hold. They can't really sit up at the usual stages that they're supposed to. It also makes it difficult for feeding. And then this picture just shows you what the facial features might look like the narrow nasal bridge, almond-shaped eyes, thin upper lid, turned down mouth. And this right picture shows you how obesity might affect the child as well as make it difficult and affect other body systems. So, in a lot of the research, they talked about the phases of the disorder. There was only two phases that would describe the childhood and adulthood, and then as research got more advanced and time went on, they had split phase one and two into two parts, and then they added phase zero, and then they added phases three and four. So just to begin, phase zero is in utero, which is inside the mother during pregnancy. There's about 85% decreased fetal movements and a lower birth rate in BMI compared to other fetuses. This, while this is can be common with other syndromes, this is why they do some type of testing while in utero. So for the first phase, phase 1A, this is about 0 to 9 months. This is where, when I talked about in the last slide, where the fetus might suffer from hypotonia, this is where you would find that. And then there's also the difficulty feeding, so the baby isn't able to latch onto the mother, as well as other forms of feeding, like feeding bottles. In phase 1B, this is 9 to 25 months. The baby usually, or the baby to the toddler, has a normal appetite and they might no longer need assistance with feedings. And then when it goes to phase 2A, this is more so their toddler years. This is crucial in the development of obesity, just making sure that the child doesn't overeat. Because if they do go over the daily recommended limit, this could lead to the possibility of obesity. And then in phase 2B, this is about 4.5 to 8 years old. This is typically your elementary school ages. Because of this, because this is the typical age of elementary school and the kids aren't really around the parents as much as they should be, it makes it harder for them to control their diet. So there's becomes an increased interest in food and curiosity in food that also increases their appetite, and then they start eating whatever's within their line of sight. So you know how typically you might leave like snacks on the table, or you just might be out and somebody's eating food. They have the tendency to want to go ahead and grab onto their food and eat it. The one thing about this phase 2B is that they notice that individuals at this age can feel full and they will stop voluntarily eating. And if not, they are redirectable enough that if you do tell them to stop eating, they will stop. In phase three, this is typically the longer stage. This is from age 8 to adulthood. So from here on out, age 8 to I think 12 or 13, that's middle school, and then 13 to 17 and 18, that's high school. And we know that if you have teenagers, you know that, or if you were a teenager, you know that that's when your hormones are the most they fluctuate the most. So this is where you might see more erratic behaviors from the individual. This is where hyperphagia becomes more prominent. Erratic behaviors, when I say erratic behaviors, this can include like stealing money for food, eating from the garbage, getting food and hiding it under beds, hiding them in closets. I know an individual, one of my colleagues, who works as a direct support professional for somebody with PWS, and they have explained to me how like it can be difficult because you also have to make sure that you lock away the food. So they'll lock the cabinets, the fridges, the pantries, just so they don't have easy access to these foods because they might not feel when they're getting full. I also read somewhere that over a weekend, there was one individual that gained over 20 pounds just from eating. So this is when a strict diet needs to be in place so that these individuals don't reach obesity. And then finally, in phase four, this is adulthood. The appetite is no longer insatiable. There is some appetite control, and they're not as preoccupied with food as they were in phase three. And there's also less tantrums, but majority of these individuals with PWS will not reach this phase. But there are cases where individuals have. So for diagnosis, majority of the testing is done during pregnancy, especially if there's an assumption that the baby will have PWS. So the first type of screening is called a NIPS. This is a non-invasive prenatal DNA screening. It's a blood test that's taken from the mother, and it is commonly the most commonly recommended test for pregnant women. This allows for early intervention and the ability for the parents to learn more about the disease so they can properly prepare. The next one was methylation analysis. This method is used to study the modifications of DNA and histones by methyl groups. This test detects for more than 99% of the cases, and it tests for all the three major chromosomal abnormalities outside of the pregnancy. So this tests for the paternal paternal deletion, the maternal UPD, and the imprinting defects. And then the fluorescence in situ hybridization or the FISH analysis. This is where pathologists will mark DNA with fluorescent labels so they can identify the sequences of the DNA. So here, this allows scientists to get a closer look of chromosome 15 and see which parts of chromosome 15 are missing and in place, and how the phenotypes might be presented in the within the individual. So, with the advancements in medical treatments, there were three types that I saw. The first one we're going to discuss right now is hormone therapy. It seemed to be the most popular throughout the research. So, with growth hormone therapy, they found that there was an improvement in body composition, psychomotor development, cognition, adaptive function, linear growth, and this was without adverse effects on the glucose metabolism or blood pressure. The growth hormone therapy was mostly used to help fix the more um, phenotypical aspects of the disease, so the short stature. It sort of helped with the underdeveloped sex organs. But it helps reduce fat mass and increase lean body mass, changing the clinical phenotype of the children with PWS. So there was a 3-year continuous study that was done with young adults with PWS. There was body there was positive body composition changes that were initially observed with GH therapy, and those changes were maintained from childhood all the way into adolescence, which is a good thing. And it also showed how early intervention can be important for people that suffer from this disorder. So for more on the pharmacy end of the disease, most of that focused on the hyperphagia, which is the overeating. So ghrelin is the hunger hormone. So with levolytid, which is AZP-531, and ghrelin O axotransferase, or nicknamed GOLT inhibitor, it helped reduce ghrelin by more than half. And then with leptin, it's a feeling of satisfaction. It's a hormone that leaves you with a feeling of satisfaction and inhibits hunger. There was no drugs that specifically targeted it, but beloranib was an attempt to improve leptin sensitivity. And it seemed to help, but it didn't do exactly what it needed to do in regards to reducing the amount of leptin within the system. And then insulin secreted, as we know, insulin is secreted by the pancreas and it regulates blood glucose. This signals for satisfaction after meals as well. So a medication or a drug that was tested within the study was diazoxide, and this is a potassium channel activator. So this helps to control the insulin secretion and improve to reduce fat mass. And then for the last medical treatment, this was hormonal therapies for hypogonadism. So hypothalamic dysfunction gonadotropin is responsible for releasing the hormone GnRH, and deficient production of luteinizing hormone LH, as well as follicle stimulating hormone FSH and sex steroids. Um, so with hypogonadism, all of these hormones are diminished, and it doesn't allow for the proper sex organ as well as the reproductive system to properly grow. So there was two different studies that were done in two different papers. One was on males and one was on females. In the males, they did a testosterone replacement therapy. And the benefits of this was increased lean body mass, improved mineral density, and enhanced energy levels and well-being. The adverse effects of this was increased aggression, irritability, and emotional instability. That being said, um, it it not only affected the sex hormones, but also your other hormones such as dopamine, and that's a issue that was found throughout the paper. And then in females, they did an estrogen replacement therapy. So benefits included improved bone mineral density, and it also aided in the development or maintenance of secondary sexual characteristics and possibly improved mood and quality of life. But like the study that was done on the males, there was a similar adverse effects that were observed. And another thing with this study was that it particularly lacked a specific protocol that was consistent for all the studies, for all the participants, because they weren't all staying in the same area. They didn't have control of their diet. So it really is hard to tell why these adverse effects were happening. But from that paper, they were able to come up with this sort of treatment plan to where they feel the testosterone should be pulled in and pulled out. So first things first is that they'll screen for hypogonadism, and based on the testosterone levels, they might tell them to come back again in another year, or they might start with a low dose of the TRT. So then they'll begin the treatment. And then as time goes on, they'll begin to increase it. And if there is no adverse effects, then they will increase the TRT dose until the testosterone levels are within a normal range. If not, then they go back to where they bring the dose back to where it was there was no adverse effects and is with an acceptable range. But individuals, once they start to have those adverse effects, they aren't able to increase the doses at all. And hopefully research down the long run is able to fix that. So now for the advances in neurocognitive interventions. So for more behavioral therapies, this is more so focused on where these individuals are receiving their therapies and who it's coming from. So the main source of behavioral therapy is through their caretakers. So this might be with mental health techs, behavioral health techs, direct support professionals, CNAs. They did a study and it was revealed that a lot of the caregivers feel unsupported. There was a lack of resources, difficulty coordinating with practitioners, specifically practitioners that knew enough about PWS to give proper care plans. And there were also, because there's such a small amount of practitioners that are focused on PWS, there's an inaccessibility to those providers. They also found frequent issues with tantrums, repetitive behaviors, and rigidity. And then when it came to trying to deal with the tantrums and repetitive behaviors, they have found that applied behavior analysis, or ABA, was ineffective for many reasons, and it is not broad enough to be applied to every situation, as every individual might be different. But they felt that there was an overall need for the increase in support so that they are able to properly take care of individuals with PWS. And then with neuromodulation therapies, these are more so electrical currents that are ran through the brain to see how this might affect the individual and their reactions. So the first one is a vagus nerve stimulation VNS, and this was used to target aberrant behaviors on hyperphagia. Then there was the transcranial direct current stimulation. This sends a low intensity electrical current over the scalp. This helps with improving self-regulation and decreasing certain unpredictable behaviors. Then with repetitive transcranial magnetic stimulation, or RTMS, this enhanced emotional control and lessened hyperphagic behaviors. And then last but not least, deep brain stimulation. Here, this targeted deep brain structures assumed to influence appetite control and emotional regulation to help lower symptoms such as hyperphagia. Sorry, I'm like trying to get through this. So for our discussion, as the limitations that I stated earlier, as I was talking about the research, the big issue was that there was a lack of long-term studies. I think I only saw one 3-year study as I was looking for things to add to my paper. There is also a lack of research, especially with the hypogonadism. It kind of seemed like the research kind of stopped where it was at when it came to the TRT and the ERT treatments, which is kind of sad only because that means that individuals that do get those adverse effects aren't able to reach their full level of potential when it comes to receiving testosterone or estrogen. There was also, like I said, the inconsistency with the studies as they didn't really have them in controlled environments, which is hard with people who do have mental disabilities. Preventative strategies that were also prominent was early diagnosis, early interventions. As we saw, the earlier they were able to give the testosterone as well as the growth hormone therapy, the more long-lasting effects that were saw from childhood into adulthood. And then another thing is big support for the families and workers, as it is not easy to deal with individuals with PWS, but with the proper support, it can make their quality of life as well as their family's quality of life a whole lot better. And then finally, to close out this presentation, just to repeat myself again, Prader-Willi syndrome or PWS is a very complex disorder that requires different types of therapeutic and pharmaceutical interventions. Advancements in therapies have seen an overall positive effect on individuals, but gaps in research, to fill those gaps, all we have to do is redirect the studies, elongation of the studies, and also fixing the underrepresentation, especially when it comes to females within the research. Hopefully, with future research, it applies more to personalized therapies and preventative strategies that help to improve their long-term quality of life. So that's all I have for my presentation today. Thank you for listening in, and hopefully we will see more in the future about changes within the PWS community. Thank you.